In a world of EMS podcasters, EMS Office Hours is the only live podcast bringing you the latest topics and opinions in EMS. Turn down your scanner and turn up your speakers as we join Jim Hoffman and Josh Knapp on their latest EMS podcasting journey.
All right, everybody. Josh, you made it just in time. Just in time. Yeah. So I just want to thank everyone that's joining us live today. I always fail to say this, and just to tell people that I really appreciate you guys taking the time to join us. If you're joining us live on Facebook or YouTube, or you're watching the recording, listening to recording. So I just appreciate you for doing that. I know we're all very busy out there. So, if you're getting something out of the show, whether it's a laugh or a little piece of information that might be helping you out, just hit the like button for me, share this, let other people know about it, because it really does help the show, as we go forward. So, of course, I am Jim Hoffman, and that's Josh Knapp.
And I'm Dave Brenner.
So,
do I need to even talk now? Because you
need to crank up your volume.
You're a little low, Josh. So just make your sound a little bit louder for us.
I am trying.
While you're doing that, Dave, the reason why today's show, you had sent me an email, which I thought was pretty interesting, and brought about something that I think a lot of people either think about or even may have done or refuse to do, which is act as an EMT or a paramedic when we're off duty and we see somebody that's injured or down or what have you. And I thought it was a good topic because you get a lot of people who talk about the duty to act thing and, being sued, stuff like that. And I think that that's a big part of what drives people's decisions when they either act or don't act or hesitate. But I think there might be other things involved too. So I'd love to hear your thoughts on it. I know you said you had sort about it. There was a percentage of physicians you had said that do that, and I was just wondering, maybe you can just give us a little insight.
Sure. So actually, before we move there, why don't we just do this? Have you ever done it?
Yes.
Josh,
ever done respond to somebody while not on duty?
Yeah.
Or before I was in EMS, respond to somebody?
No, once you were in EMS, a credentialed provider.
Plenty of times.
So I'm going to set a stage, if you don't mind, all right?
Go ahead.
I was once in Macy's, and we were waiting online, and there was a young lady in front of me, and I'm watching her just stand. My wife is right next to me. She's with her mother. She was about 16 years old. And I said to my wife, she's going to collapse. And she did. She fell. I caught her under her armpits. I lie her on the ground. I elevated her legs. My mother said, "What are you doing?" I said, she passed out, and that's something I've done a whole bunch of times, not catching women, but responding to people.
But when she said, "What are you doing, Dave?" Did you identify yourself? You said, "I'm paramedic."
I said, I did. I said, "I'm a paramedic," and she passed out. I caught her so she wouldn't fall. Yeah, I did the right. They didn't question that, but I've responded to a lot of people a lot of times, and that was an easy one. Did you ever respond to anybody in a restaurant or on a plane?
On a plane, yep. I had to sit with this woman for 3 hours. It turned out to be possible middle smirch. Middle smirch,
yes. Okay, yeah, that's
middle smirch.
painful. That's
middle
painful.
smirch. Right, right, and she had passed out, and I did the exact same thing, laid her down and whatnot. They had oxygen on her, and kept that going until the color returned to her face and her mental status improved.
I don't doubt your care. I'm not questioning the care, but you responded, right?
Mm-hmm.
How about you, Jim?
It's funny you bring the Macy's story up, Dave. I had almost an exact thing happen to me in J.C. Penney.
Oh, there you go.
Maybe
that's where she went next.
I was poorer than you. I didn't really shop at Macy's. I had to shop at J.C. Penney, and I was online and I watched this kid. He must have been maybe 10, 11 years old. Start having a seizure. And I would do the same type of thing. I took off my shirt and I peeled back the Superman, symbol.
Yeah, sure.
And I walked
Did you
over.
Look around and grab a bike?
And I said, "Is there anything I can do? I'm a paramedic." And in my back of my mind, I'm like, "I don't know. Is there anything I can do? Because I have nothing with me."
You got midazolam on tap.
But I will tell you, the staff at JCPenney came. They brought a wheelchair and they brought oxygen.
Sure.
And the thing is that just the fact that I identified myself as a paramedic, and as they're waiting for the ambulance to come, they seemed more at ease.
Oh, sure.
Knowing that that there was somebody there who was, I guess, higher qualified.
5 minutes before that, they were unboxing shirts in the warehouse.
Exactly.
And thank God there's somebody here who knows what's going on. They just like a response.
But I'll tell you, on the flip side of that, I was on a plane once, and there was a guy who had a syncopal episode in the plane, and he was in the back of the plane, and they asked if there were any medical personnel on board, and 2 doctors got up and went back there, and I was like,
it was a podiatrist's flight to Las Vegas.
I was like, all right, what am I going back there for? The 2 doctors back there.
This is what you do.
So in that case, I did not get up and volunteer my expert services of a non-equipped and paramedic in the skies. You know what I mean? So
there is a recommended first aid kit for airplanes that has some interesting stuff on it, including saline and IV access and stuff like that.
Oh yeah,
yeah, but there are no health police checking that stuff.
Well, I did figure though. I said to myself, in a situation like that, I've been in a few situations like that where I kind of held back because the patient they weren't unresponsive, they weren't doing CPR, things like that, and there were other people already injecting themselves into the situation. So I'm like, okay, why am I going to get up and be another person to get up with no equipment and say, hey, I'm a paramedic, whatever. But but at the same time, if the person was cardiac arrest, something like that, that would change the situation.
Sure would.
And
so let me ask you something. Dave, I apologize.
I want to bring you to the next part. The next part.
Well, before you get there, when you get on a plane or some conveyance of that nature, where there's somebody greeting you, there's somebody in charge of the transport, like a stewardess or somebody. Do you let them know that as you're getting on? By the way, I'm a paramedic. Or
you're asking me?
Yeah, any of it. Yeah, it's open to the table.
For me is yes. I usually say something. Listen, I'm a paramedic. It'd be good if you don't need me, but if you do, I'm here.
Right. And I used to think that was a sort of a geek thing to do, right?
What
do you guys say, Jim?
I say I'm a paramedic and I like a window seat and a free beverage.
And an extra, yeah, right.
And
I take scotch.
And they say, no, you're not a doctor. EMS is different. Go sit down and shut up.
So my experience on the plane was sort of similar to that, because I when I get on a plane, I usually whisper to the stewardess that, I'm a medic. Please, if you don't not whisper.
Don't be whispering to stewardesses, Josh.
My wife gets upset at that. No, it's but I usually will say, hey, I'm a medic. Hopefully you don't need me, but just so you know. And the response I got on the one time, most of the time it's very polite, thank you, good to know, or, something encouraging along that line. The person, the stewardess that on the last flight that I had somebody who went down, basically said to me, well, thank you. We have everything under control, sir.
Yeah.
Go, please enjoy your seat or something like that. And me, it was back in the day, and I don't know if you remember these days, Dave, where you could work more than a 12-hour shift in a row or several 12-hour shifts.
You can still do that.
Well,
yes, you can.
The city system is harder to get around.
No, it's not. I see it all the time. They work 12 hours in the city. They come out to Holbrook. They work 16 hours straight for us, and they go back to the city.
So they're working two different. They're working
out of the city.
Municipalities.
Yeah, sure. They
right.
do it all the time. You don't think it happens in Westchester?
Yes, you're right. You're 100% right.
Everywhere.
Still, maybe that's a topic for us in the future.
It is.
But anyway, my interest was to get to in an uncrowded plane and get 3 seats across and not wake up until we touched down. And that plan was going perfectly. I had, as soon as the seatbelt sign went on, I sort of threw a belt around me, laid down in the seat, and told my wife that wake me up when we're disembarking. And I felt that nice, gentle lift in the air. I'm falling asleep. I'm in the clouds. The plane's in the clouds. Everything's right in the world. And then the tap on the shoulder. Sir, did you say you were a paramedic, sir? And then we had my pass out.
Everything is under control.
Everything is under control. And I said, do you have any equipment? Do you have anything? She said, well, we have a red bag, a red package, and a black package. And I'm like, well,
which one has the peanut?
And I said, she said the red one has a tag on it. So I said, okay, that probably has drugs in it. I'll probably want to see that, but let's see what the situation is first. The black one, do you remember the kit you got in EMT school?
Yes.
The little black bag with the blood pressure cuff and your $2 stethoscope? Right? Yep. That's exactly what they had.
And the crappy oxygen wrench?
No, they didn't at the time, but I luckily always carried mine. So
here's the next question. You guys worked the mean streets of New York City, did you not?
Sure.
They were very happy streets.
All right,
very fun.
Did you ever? We have off duty on the mean streets of New York City?
Maybe.
Yeah. Ever
Are
go to
there
a Broadway
cameras?
show? Ever go downtown into to Little Italy or somewhere like that, or to the restaurant district, or you ever see a person lying on the ground there, disheveled, looking undomiciled? Possibly, just looking disheveled and undomiciled. Yeah.
Once or twice.
And let me ask, if they were overtly seizing, what would be your response?
Call 911.
Yeah. What would you do for the patient?
It
would be different. It would be different than if you were waiting online at the Met and the person in front of you in a tuxedo went down and started seizing. Might it not be?
Yeah, they're in a tuxedo, so I'd pat them down. They might have something valuable in their pocket.
WABC, wallet, airway, breathing, circulation. Right. That's the New York City. All right,
Ow. New York City doesn't appreciate that.
Yeah, I'm just joking. So there was an article in the Journal of the American Medical.
Angry emails to Dave Brenner. No, go ahead. I'm sorry.
It's just sarcasm, and
yeah.
So there was a recent
backpedal that now.
I don't have to backpedal it. Yeah, they can fire me from my medic job.
So we're at the Met. You have a guy in a tux, and you're saying that he's going to be treated differently than the guy outside the Met.
So there was an article in a July Journal of the American Medical Association, not research, it's a viewpoint. It's called The Clinical Approach to Preventing Death on the Streets. And they asked a lot of docs. And if they would typically jump in, and most 69% of physicians report that they would definitely help and provide help in a restaurant, diner, someone clutching their chest. 54% said they would definitely respond in an airline passenger. 2%, however, report definite willingness to help a disheveled person lying on the sidewalk.
That person is seizing or obviously have something going on other than being homeless and sleeping or disheveled and drunk or something like that. Like laying in their own vomit, let's say, because they drank,
Yeah.
So a quick theory or observation to that, it might just be a level of experience as well. When a doctor sees a patient and clinically gets into the mode of thinking clinically and healing, they're in a fairly clean office. It has all the accoutrements that they need to diagnose, and they're in their own environment. For EMS, we're more used to the streets. I mean, every one of us here has treated a homeless person more than once, and sometimes they've been, a lot of times they're drunk, they're in their own vomit, or just drunk or passed out or just sleeping, right? But occasionally you got somebody who is, in extremis. But we've treated them, right?
Sure,
so when we go, when we're by the Met, and we're not in a rented tux or anything, and there's somebody on the ground outside, I would think that a person with experience in that situation would be more likely to go to action than a person without experience.
But also, just to be clear, while they're used to an office, I'm used to a partner with a radio.
Right.
I'm used to a system backup. Right. So yes, I'm used to kneeling on the street, and most physicians probably are not. But it's just healthcare providers in general. But this was, in the journal, and so they checked. But it was interesting to me that only 2% of them said that, given really the same circumstances, a homeless, disheveled person would get their attention and care. And so I think there is a difference between what they do and what we do. And they also put in there, people are worried about Good Samaritan laws. In New York State, there is no Good Samaritan law. There is Article 3013, which is the release of liability for providing care without expectation of compensation, which is tantamount to a Good Samaritan law, which, by the way, applies to physicians as well as EMS folks.
Right.
Yeah. I'll say, like you said, if I saw something like that and they were disheveled and actively seizing, I would say that I would, like I said, I would call 911. And I don't know, again, not having equipment or a radio or a partner and things like that, I'm not sure what I would do, maybe other than you make sure nobody try to be a hero and stick something in the guy's mouth or, something like that, that type of thing.
I mean, what's the bottom line BLS protocol with seizure is to keep them from harming themselves and maintain an airway.
Again, I'm not interested in our ability to recite. I know we know what to do, but that's what we do. We're EMS. We don't have to MacGyver it. We don't have to, go search and get a spoon, bend it into the shape of an OPA. We're not doing that. I know we know what to do. These aren't even medical questions. They're more social and ethical questions than they are otherwise. So, but they came up with an algorithm. They came up, believe it or not, the clinical approach to assessing a person experience homelessness on the street.
Wow. Okay.
So you know what they came out with first? The BSI dance. Assessing safety. The BSI dance where you put your hands up.
Jazz hands.
And that certainly makes sense. And the is it safe to approach? I think that's a perception thing. That doesn't mean that their pit bull is standing by them growling. Their hungry pit bull. It simply means, do you feel safe approaching? And if not, it was real simple. They said, call local resources. And that's where the algorithm ends there. So, but the other side is it safe to approach? And there's no surprise here. And it works so easy for us as for them. Assess for alertness. Wow, what a great idea. What a great idea. Yeah, and if they're alert, assess for clinical distress. Are they in acute distress? Or are they not in acute distress? If there's no acute distress, here's what they said: consider engaging. It's interesting. By the way, the responsibility to provide care differs from state to state. You know that, right?
Right. It is a state thing, but I don't know the degree that it differs.
I believe, Josh, and I could be wrong on this. I know this for New York State. I could be driving by an accident. You and I could have left the restaurant. You left ahead of me, and I see that you slammed into a hydrant. Your head is sticking through the windshield, and I can just go by and wave to you, and you go, Dave, paramedic, you're my friend. And I said, you thought I was your friend. But yes, and I can drive by because I have.
I gotta get home.
I gotta get home. I gotta get home because I have no duty to respond. I believe, and I could be wrong, and I'm sure everybody from Vermont will correct me if I am. In Vermont, the rule on the road is each person has to stop and provide care, if necessary, to the level of their credential. And that doesn't mean a surgeon has to operate on somebody. It simply means that if there is an accident and you're the first one there, you need to stop. You need to make sure EMS, is called. If necessary, EMS is called. If there are people hurt and bleeding, if there's anything you can do, you should do. And you're not expected to do something that's beyond your scope of practice, and you're not expected to perform surgery on the side of the road, but you are expected to provide care, reasonable care to the level of your training. I could be wrong, and I'm sure if I've lit up the board at all, because that one person in Vermont who was listening to us, who serves on the health board for the state, says, Dave, you got it all wrong. But I think that's the case.
Well, what do you think as far I think that a lot of people's arguments are the fear of being sued, or the fear of maybe the job, the organization that they work
with
for.
Disease?
Yeah, things like that where you're not equipped, and the fear of disease, the fear of you getting hurt, the fear of again, getting sued if you do something, even if you don't cause any harm to a patient. Maybe you get somebody who gets it in their head that they want to try to capitalize on the fact that you stuck your nose in where you didn't really need to stick your nose in.
Or you did the right thing and maybe they want to capitalize. We see that all the time, and they don't have to be homeless or disheveled.
Exactly.
We see.
I think I think you're probably better off with the disheveled person, because they're probably less likely to try to sue you than somebody who is in the tuxedo. And I think that's like the biggest thing. And like you said, Dave, different states have different laws and different things in place that protect people if they step in. Some places where they if you're a firefighter, paramedic, and you work for the city, you're considered to be on duty 24/7. So if you stop, you're covered under the city's guidelines. You know what I mean? Whereas other ones is like, once you punch out, okay, see you tomorrow, and don't do anything stupid. You know what I mean? That's the line, I think, where a lot of people start to hesitate. I mean, listen, I did a concealed carry class, and the whole thing was, if you see somebody getting beat up or whatever, or somebody's pointing a gun at somebody else, don't go over and pull your gun out and try to stick your nose in, because if you end up shooting that person, you'll probably go to jail.
Yeah. Even if you're covered by the Good Samaritan laws or whatever they may be, if a person sues you, that doesn't mean you don't have to hire an attorney to defend you.
Right.
That costs money. But I want to show you some interesting guidelines. You know, it's they've got one here. You assess for alertness and they're not alert. Then they say assess the weather. In extreme weather, just call local resources. That makes sense. That makes sense. On the other hand, if the weather's not extreme and you check their breathing and they're breathing normal, it says continue walking. As Dionne Warwick said, just walk on by.
I like that one.
Yeah. But if the breathing is abnormal, attempt to waken them.
David, just like an algorithm that's like on a screen.
It is. You know what? And if I could, I would just drop it here. Or I don't know how the copyright laws work regarding journal articles right now to put them on the air.
All right.
I mean, I'm certain we can talk about this, but it's not like I'm sworn to silence.
But Dave, what they're basically saying in this article or presenting in this article is, for lack of a better term, a set of protocols that
guidelines.
What do all our protocols say?
Guidelines. These are just guidelines to good care that don't take away professional good clinical judgment.
Right. And they're just basically a stepwise procedure for somebody who's not oriented to I don't know about that. I think there is an orientation to that if you take the ACLS or PALS program. They're very stepwise, assess and then treat.
Of course. I mean,
isn't that all about medicine?
Standards are all about lawsuits. Standards and guidelines. Can you point to something in the professional realm? But the interesting thing to me is
walk on by.
Well, not the walk on by, but this is for homeless people in the street. There's a social commentary in this that flared when they did their survey of physicians. It wasn't St. Teresa, the response. I'd be right on the floor with them right there. That's not what they said. And then they do some attempt at some silly medicine that they did here. If it's bad weather and they're not breathing, it's got to be bad weather though, just so you know, or good weather and the breathing is bad. Assess pulse, call EMS. If there's no pulse, well, if there is a pulse, they talk about giving naloxone. Just pull that out of your wallet.
Right.
And rest your breath.
The naloxone paste, you pull it out next to your condom and you take it out and you rub it on the patient's chest.
And if there's no pulse, they say administer CPR and naloxone. I don't recall in ACLS. I do recall ACLS. They said there's no clinical evidence that using naloxone in a cardiac arrest is useful. It's for respiratory depression, but it doesn't take a person out of cardiac arrest. So, but all of that aside, I felt it was interesting that they had to say this. This was an imperative. This was something they needed to say. So I thought that was pretty cool. Is there a way for me to share a file with just you guys?
I don't think so.
I see I'd share a video file. Oh, I have this crazy thing called email.
Right. You can definitely do that.
Yes, I think I can. Let me see. Oh, yes. All right. So what do you guys think about the fact that they actually had to make a statement on this?
Well, I mean,
what do you think of the 2% rule? It's not a rule.
I think there's a couple of conflicts right in there. I mean, just the idea of, look, somebody in the end was paid to write an article and that article was shared and it's publish or die, right? So right.
Well, that wasn't an article. That was an opinion.
An opinion, even more so. So it's an opinion, but it's content for this. They're putting it out there. It raises some interesting questions. I think the greatest question it raises is the idea of why are trained clinicians so reluctant to respond outside of their clinical setting. Or they're not. Actually, it's not, because they said that they would if it was, a person in like a theater or something like that. But homeless on the street is a different layer.
Now, I can't generalize that to nurses, because this was specifically asked to physicians. So I don't know. I don't know how nurses would respond to that. I've worked a cardiac arrest at the airport, and a guy stopped. He said to me, "Listen, I'm a physician. Do you need any help?" We had a full crew. We had the guy intubated. We had everything going on. And he says, "My son," he points to his 15-year-old son. He says, "My son told me I should stop and offer help." And I gave his son the thumbs up. And, as if to say, thanks for doing that, which was really very nice. And I said, "By the way, what's your specialty?" He said, I'm a dermatologist." And I thanked him again. And when he left, I turned to my partner. I said, "Listen, if this guy gets a zit, go find that guy." So,
right.
That's not really true. I mean, that doesn't make a lot of sense.
They're trained in basic CPR, aren't they? Anyway.
Yeah, maybe. I mean,
he could have done compressions or at the minimum.
We had the clown crew. We had like eight people there.
Right.
Listen, I'm not putting down dermatologists. It's this is what we do. I mean, that's our specialty, is care on the streets. And
it's the same thing if you went to his office and said you need help with that popping that zit. I saw it on TV. Dr. Pimple Popper, I think I can do it.
Yeah, it's exactly right. Exactly right. So I just sent it to you guys if you wanted to see the algorithm.
Yeah, I'll take a look at it. Can't share it though.
I sent it to you. I'm not,
You're absolving yourself of any shares.
I just said an excerpt. Anybody who wanted to. This is from the the Journal of the American Medical Association. I was able to get it on July 8th. I suspect it was published on or about that time. It was great. It was great.
I'm looking at it on my email screen. That's quite the little.
Yes.
Did I send you the whole article or just the?
I just got the
algorithm,
the image. That's some algorithm. I'll tell you, it's holy cow.
Yeah. I would walk around with that in my pocket. No, it's just a guideline. You read it, you get a sense.
I wonder if I printed it out and I laminated it, if I could sell it to doctors to keep in their wallets.
Wow.
Brutal, right?
I've had a bunch of doctors stop. We had a guy that was clobbered by a car on the side of the road at night in the rain. And there was a medic there trying to tube him, and he just wasn't having any success. This guy pulls off of one of the main roads. He pulls over. He says, "Can I help?" And they said, "What do you do?" He says, "I'm an anesthesiologist." And the guy says, "I'm trying to tube him." He says, "Give me that thing." He tubed him in about a half a second. Boom, on the floor. He just went right into the grass, tubed the guy in a half a second. He does a dozen tubes a day.
Right.
That was wonderful. Down and dirty, there he was. That was great. And then he went on his way, and I said, "Who was that man?"
Right.
Who was that man in the BMW?
Yeah.
So what do you guys think? What do you guys think that the takeaway is on this? I mean, should we be stopping for anybody? Should we know what our local, whether it's New York, California, wherever, should you know what your local laws and whatnot are before you step in, to know the risk that you're beyond the risk of, like you said, Dave, a disease or maybe a patient getting violent or something like that. What's the risk to you? Financially, legally, things like you said, you can have someone suing you even if you're 100% in the right. And it doesn't mean you're going to get in trouble, but it does mean you might have to spend money on a lawyer.
Well, I think it's a few things. I think the first thing that it says to me is that the time to think about this is now, while you're sitting at home in front of your computer and no one's lying on the floor in a pool of vomit.
right,
or collapsing on the train station. How many of those folks do we see? Yeah, listen, you've been to Penn Station? There are people who live in Penn Station in the winter.
right,
Because, and they're sleeping because they're sleeping. It's time for them to sleep,
right.
I think the decision on this stuff should be made before you're confronted. I don't think the time to make a decision, or at least to have an orientation, is in an emergency. I need to think about it in advance. I want to have my routine. I don't want to plan for every contingency. I'm not walking around with a 14 gauge needle to do a needle decompression on somebody I see on the trains.
But there are people who do.
Wait a second. There's some reasonableness to that statement, Dave. Because when I first became a paramedic, it was sort of a discussion amongst new medics. There were guys going out and getting tube kits for their car. And I'm like, what are you going to do with that? You tube somebody on the street and you've entered into a world of hurt. Whether it's successful or not, even if you save the guy's life, there's a very good chance that you're going to get nailed for operating outside of your guidelines.
Yeah.
Oh yeah, and I don't even think I wouldn't be allowed to bring my own tube kit to my ambulance. It's supposed to be the agency's tube kit. It's been checked. It's been maintained. There's a load of liability if you come in with your own stuff.
Yeah.
That's
another argument too. I mean, listen, I
don't have the right to walk around with 14 gauge needles or even 22.
Remember glucometers? I mean, we still have them, but remember glucometers not being on the ambulance because they weren't, because especially if you're part of exactly, where they said, we have our equipment, it goes through our own biomedical, it has to be assessed that way. Your equipment, we can't judge if the reading is accurate. And you're sitting there saying, I just need to know if it's high, low, or normal. I don't care about, is it 139 versus 142, but they do. And it took a long time before they came back and they said, okay, well, we'll allow glucometers on the ambulance. And then when they had these little finger pulse ox meters, there was a whole big thing about, having them because on BLS buses, because it's outside of the protocol for BLS.
Yeah.
And, eventually they
going on, people, like you said, Josh, people bringing their own sort of equipment like that and then being dumbfounded when they were told they couldn't use it on the ambulance.
Except oxygen wrenches. You're allowed to bring your own.
You can't use your own. That's true. You can't use your own.
Or even better, you can get your agency to buy it.
Right here. Buy the oxygen wrenches in bulk so that every ambulance has a couple.
That's it. Right.
No, but it's true. That is true, though. You had people that bring in their own glucometers, their own pulse oximeters. I remember just about everyone I bumped into had that little finger probe, going on that they would use, and that goes back. But then that goes back to what I was saying, that people that carry that stuff, let's say in a little bag in their car or whatever, and they stop and they render aid and they use their own glucometer or their own pulse ox or whatever, again, I guess it goes back to the local laws and whatnot. If they use it and the patient comes back and complains, is their use of that pulse oximeter, whether it made a difference in what they did or didn't do or not, you'll get some lawyer who will say, well, why did you use that? And it's another sort of nail in the coffin for you as the person who stopped, that you used something that you weren't authorized to use,
Sure.
And I think that most people that you'll speak to will tell you, oh, I'm not going to stop. I'm not going to chance getting sued. Well, what am I going to do? I don't have a trauma bag with me. I don't have a medical kit with me. I'm going to stand in my hands in my pockets waiting for the ambulance, and I'm putting myself at liability for doing something too much, or maybe not doing something. If somebody finds out I was a medic, I didn't do enough.
Right. Yeah, I hear that all the time. I've heard it from a lot of healthcare professionals. They say, I'm not putting my license on the line for this. for this, whatever this is.
Right.
What I really want to do, and I've sent you guys the entire article.
Okay.
All right. I want to read the last paragraph. It won't take long, I promise. But this is my take-home point. It says, although there is no legal obligation to intervene when walking by a person in need on the street, clinicians arguably have a professional responsibility to help, consistent with major medical society codes, which recommend that physicians provide emergency care when needed. And they give you a reference for that. All 50 U.S. states have enacted legislation to protect healthcare professionals who act as good Samaritans, except in instances of gross negligence or willful misconduct. Listen, if a person's choking in a fast food place on a hot dog, and you say, oh, I'm going to relieve that with back blows, and you take out a baseball bat and you slam them on the back with that, willful misconduct or gross negligence, that's not covered. But if you do the right things or intend to do the right things, if you do a Heimlich maneuver and you break a rib, right. That's okay. That's okay. So if our duty as clinicians is to care for those in need, this is my favorite line of the whole thing. Then never again should a person die alone on a sidewalk without an attempt by a skilled passerby to prevent another avoidable death. That's a line I can live with.
Yeah. I agree.
That's the line in my head. And I would say to people, if it's not the line in your head, maybe you should have, been stacking books at the library or something. And if you miss young Tom Sawyer, no one dies. But that's my line.
No, I can definitely agree with that.
What a liberal I am, huh?
It's horrible, Dave. No, but I can agree with that. With that mentality. The question is you got to get people past their fear of litigation. And life disruption. If something like that happens, people are like, never mind losing your license, right? It's just a fact that, oh my God, now I have so much stuff on my plate. Like Josh often says, as EMS, providers, a lot of us work 2 jobs, maybe 3. Now
Josh works every morning from 5 a.m. to 9:45 a.m. That's why we can't start this till 10.
Yeah,
that's
true.
You got to wrap yourselves around that fact. I just can't.
But the
stop.
thing is that you say that to yourself, it's in the back of your mind, and you're like, okay, if I stop and do something and I get in trouble one way or another, whether it's positive, negative, do I need that additional headache going forward where now maybe I can't work a shift or I have to spend time in court to defend myself for doing the right thing, type of a
do you really think, though, that, because I have to say that that's probably of the 50 things that are going on my mind, the legal jeopardy that one places themselves in when they interact with a stranger is probably maybe 45th. I mean, it's really not up on the top.
Well, yeah, I can say that. I agree with that, John. Because I think if you see something happening as a paramedic and EMT, when you come across something that's actively happening, most of us are going to end up, I think, acting.
Right.
There's a lot of misinformation out there that has to be combated first. I've had what misinformation? Well, that you're not covered, that that you can lose your license. Well, sure, you can lose your license for hitting a person on the back with a baseball bat. Or, when they're choking, yes, you can and you should lose your license. And so that's not a problem. But that I'm not just talking about EMS folks. I've heard it from nurses. I've heard it from physicians, PAs, respiratory therapists, people who could know have said, listen, I'm not risking my practice on this. Not the disruption. That's not. They have misinformation, and there are people who propagate this misinformation, and it's just very hard to stop and clean this up so that nobody else hears it, so that we don't have to clean it up again. There's there's a story. It's about a guy who says something bad about his neighbor, and it was a lie, and he felt bad about it. And he goes to a clergyman, and he says, "Listen, I said something terrible about my neighbor, and it was a lie. How do I repent for this?" And the clergyman says, "Listen, tonight, what I want you to do is I want you to go to every house in town and put a feather on the doorstep." So it's 11 o'clock at night. The guy goes to every house in town. He puts a feather on the doorstep. He goes back to his clergyman, and he says, "Now what do I do?" Clergyman says, "Now go back and gather up all those feathers." It's like hard to stop this nonsense. It's hard to stop them. Listen, I understand if you're afraid, you're afraid. I'm okay with that. Walk away and call 911. But if you're loaded with misinformation, become informed. It can't be right that you went into a profession where you want to help people and that the right thing to do is to walk away and do nothing. That can't be the right thing. And
I think that's the biggest takeaway, I think, Dave, for this show is, I think, like I said, I think most people want to stop and will stop, right? And I think some people, like Josh said, the level of fear of getting sued or whatever is kind of low on the list of your priorities when you see somebody that might need help. But maybe while you're rendering aid, now that 45th thing, like Josh said, starts ringing the bell in the back of your head, like, okay, how much more further am I going to go here? Where I'm going to put myself at risk. But I think the takeaway, the biggest one, is, like we had mentioned a few minutes ago, is to educate yourself, to know the law in your area, know the any kind of
resources too.
Right, the resources, all that type of stuff, so that you know it. And then if you come across a situation, which I think most people at some point in time in their career will, you're going to not have that be any sort of a decision factor, And I've had situations, and like you guys mentioned, over the years, everything from a child that was drowning to the seizure thing, to guy laying on the side of the road, got electrocuted. I was a poll worker, all that stuff that I've encountered off duty, and some of it I was able to help. Some of it people denied to let me help, act like I was a nuisance more than a help, things like that. And most of it, I never really thought about the ramifications, the legal ramifications of it. It wasn't until I started getting older and more involved in EMS that I started thinking, I got to watch what the hell I'm doing, because I don't need this additional headache type thing. You know what I mean? But I think, like I said, I think the biggest takeaway for us on the show and people listening and watching is that they really need to get on themselves that education, so that they're ready if they do encounter that, and that doesn't become a factor in the decision to act or not to act. That's what I have to say about the matter.
All right.
I think you summed it up nicely.
Yeah.
Well put.
I will end it there, guys. I appreciate. Right. I thought this was a good discussion, Dave. I like this topic a lot. I'm gonna check that article as well, and maybe if I can share that algorithm at the minimum, maybe I'll be able to share it in the show notes for people. If nothing else, I can send them a link if it's not a private link, and people can go look at it themselves if they want to. You know what I mean? I appreciate everybody in the chat room engaging a little bit, giving a couple of their little pointers. And
they got some great stories.
Chat room was great today. Chat room was great.
I appreciate that. If you're watching on YouTube or Facebook, either one, thank you for doing that. Please hit the like button so that we know you're engaged and you're getting some value out of this. And of course, it does elevate the thread and the feed when people go log on to Facebook and stuff like that, so that they see this stuff for a little bit longer, before the next kitty cat video or whatever shows up. So, all right, guys. All right, that's it. As always, I am Jim Hoffman.
Josh Knapp.
And Dave Brenner.
Stay